tell you all about that at the end. I hope this is forward. There we go. I have to make some disclosures. I do speak for Alkermes, a pharmaceutical company sometimes, and I am the co-owner of an intensive outpatient program. That's me, and the title of my talk, and I'm gonna try and get through it all in one breath, is Navigating the Pharmacological Landscape, a Comprehensive Exploration of Prescription Practices and Philosophies. Thank you for whoever made that for me. All right, so I thought pharmacology was a little vague because we weren't gonna get into everything else, so I kind of trimmed it down to Introduction to Psychopharmacology, because that's kind of what we're going to be dealing with here. Psychopharmacology refers to the branch of medicine that focuses on the study of how drugs affect mood, behavior, and mental processes, as well as the use of medications in the treatment of mental health disorders. What's so important about psychopharmacology? Well, it plays a crucial part of a role in the management of psychiatric conditions. We want to offer relief from their acute symptoms. We're trying to improve their quality of life, and we're trying to facilitate recovery for individuals experiencing mental health challenges. I was reading through papers, while preparing for this, and I decided to go with kind of the historical breakdown to kind of give the backdrop of how quickly we have come to where we've come, and probably just to portray that we're probably going to see a lot more changes in our lifetime. So one of the sources I was looking at kind of wanted to break the history down into these four eras. Prehistory was prior to 1950, and I'll explain why 1950 is the date. Then we had they called it the Golden Age, where Thorazine was first invented. Then, well, I guess that's why it was prior to 1950. The third era was the mid-1960s to the late 1980s, and then you have the modern era, which is the introduction of Prozac in the US. So in prehistory, the focus, now just imagine, like, who's gonna go to a psychiatrist, right? This is, the 1800s, 1700s. What do you do with a schizophrenic? What do you do with someone who's having a manic episode? What do you do with someone who's acutely suicidal? You sedate them, and you try and calm them, and you don't have a lot of meds. So you're using opiates like morphine, you're using chloral hydrate, which they used for anesthesia back in those days, and any narcotics you can find just to chill them out, right? You had asylums, right? Like lots of huge asylums where you just lock people away. And the psychiatrists, if they're not writing meds, what were they doing? They were using psychosocial interventions. They were trying to do psychodynamic therapy with these acutely mentally ill people. And that's why they just stayed locked up forever, because how are you going to get through, right? How are you going to change some of these biological issues, these biological illnesses, using talk therapy? You really can't. And so they stayed there for years and lifetimes. So they started doing some kind of interventions to replace the use of physical restraints. Because, I've never been up there, but some of the people say that if you go up to Jackson, like in the basement, they still have like the shackles for restraints and stuff. So they were just tying them up so they wouldn't hurt themselves or anyone else. And they started doing convulsive therapy, not ECT, but convulsive therapy. Basically what they decided to do was, let's smother this person with some sort of harsh chemical like carbohydrate or something until they have a seizure. And it seems to help when they wake up from a seizure. So then, somebody's bright idea was, wait, when you get electrocuted, you have a seizure, let's shock these people and see if, they're better afterwards. And there were limited successes. And we'll talk about ECT later too, but so ECT was first really tried in 1938. And that replaced, and then when insulin came about, they decided to inject people with insulin so that they would have a hypoglycemic seizure and hopefully not die, but when they woke up from the seizure, when they gave them sugar saline solution, that they would wake up and be somewhat better sometimes. So there was a lot of experimentation, but it, really kind of took a dark turn when they introduced lobotomies. And so the initial lobotomies where they would, burr holes in the skull, and they'd get in there parts of the brain and just kind of experiment. What happens if we kind of ice pick this part of the brain? Okay, well that didn't make them better. Let's ice pick this part of the brain, and then, there's some guy named Freeman, I think, who decided, well, that's really hard because this skull is hard. Let's lift the upper eyelid and go up through the roof of the eyeball and just kind of wipe out the frontal lobe a little bit. And they did that for a while. And they thought, there was a lot of counter stuff, like people did not want that to happen, but people were doing it because, well, I don't know why they were doing it, but they thought they were helping something. Looking at it retrospectively, it was kind of almost weaponized and used maliciously though, because I saw a place where it said by 1951, over 18,000 individuals had been lobotomized in the US. 40% of them were homosexual men to try and change their orientation. So there's a pretty dark history, into people trying to treat what was considered mental illness or even other mental illness. So, then we get to the golden age, 1950. Someone makes Thorazine, kind of by accident. And we mark that as the beginning of modern psychopharmacology because Thorazine actually did something. And we still sometimes use it. It was actually our first antipsychotic. And they started getting a whole bunch of chemicals as they started experimenting with Thorazine and other chemicals like it. Metrobamate was the first anxiolytic in 1951. We don't use that anymore. You got the first benzodiazepine in 1960, Librium. A lot of places still use that to detox people from alcohol or benzos. You got your first MAOI, monoamine oxidase inhibitor, or the first antidepressant in 1951. You got the first tricyclic antidepressant in 1957, imipramine, which is still sometimes used. And then amitriptyline came around, and someone came up with the Hamilton Depression Rating Scale to actually objectively try and show that, hey, some of these chemicals are actually helping people with depression. And that's kind of when you started first having depression as an illness. People, when they talked about mental illness before that, it was the stuff that was disrupting acutely their lives and everyone else's lives, the psychoses, the mania, the delusions. But depression really, when they found a chemical that seemed to improve people's mood, they were like, well, maybe some people aren't supposed to be sad all the time. And I wanted to introduce this word a little bit, ataraxic, because they didn't call it psychosis at the time. They kind of came off the word and called these medicines not antipsychotics, but they called them ataraxics because they were just able to calm or tranquilize the patient. Because remember, the psychiatrists at that time, their main thrust was not psychopharmacology, it wasn't medicine. It was still trying to use that psychodynamic therapy, psychosocial intervention to try and guide people out of the mental illness. So the medicines at that time in the 50s and 60s were just considered as aids to facilitate that therapeutic process. So then what happened is, as we got Thorazine and some of those early antipsychotics, people started having side effects. They started getting tremors and movement disorders, and some of these psychiatrists were like, these are causing like almost Parkinson's. And so then they started talking about like, why are these side effects happening? And so someone coined the term neuroleptic at that point based upon that side effect. And that term became kind of the norm, but they still weren't called antipsychotics. I just put an ad in here for an old antipsychotic that was introduced to the US in 1954 called Reserpine. And so they called it ataraxic therapy for neuropsychiatric disorders. That was more the terminology. But if you look at the top, it's a little small print, so for those in the back that can't read it, it says opens the door to more successful psychotherapy. So we guys used to hang out with you guys, and we just talked to patients mostly. So reserpine was actually derived from this old Indian plant that they used to use the chemical like as a, I can't remember the word, but as an old medicine, herbal medicine to treat snake bites and madness. And they isolated the compounds out of it and decided to try it, and it worked some, but it had horrible side effects, and that's why it's not around anymore. I wanted to kind of put some more of these advertisements because I found them fascinating. Because you kind of like looking back now, it's easy for us to judge what some of the, like, what were they thinking? Why were they doing this stuff? But these were kind of the, when Thorazine first came out, it was kind of the cure-all. We finally had something that addressed a lot of this negative behavior, right? Like, so they were going to throw it at everything. They were going to, when the patient lashes out against them, quickly puts an end to their violent outburst. Senile agitation, give it to the old folks, right? Prompt control of nausea and vomiting in children. It's kind of the Windex of the day, just like spray it on everything. So they had syrups and suppositories. You don't want to swallow it, we'll get it in you anyway. And this part of it is going to lead into something else where for prompt and sustained relief from severe mental and emotional stress, this poor lady, right? She needs Thorazine. So then I went down this little rabbit hole of looking at, let's look at the other ads for some of the medications from that time. And if you notice something, they're pretty sexist. Her kind of pressures last all day. She's trying to bathe that little kid for Meprispan. It was that meprobamate, the first real sedative. Now she can cope. She's in the kitchen there for sodium butalbital. The battered parent syndrome. She's trying to talk on the phone. She's got the kids for Milltown. That was one of the early benzos. Now she can cook breakfast again. And they called it Mornidine. And then with Cirax, which is still around, benzodiazepine, you can't set her free, but you can help her feel less anxious. And then this one, when she overreacts to any situation. Yeah, I know, it is, right? So, but these are just the ones with the medicines. Like, if you just go look at like the old commercials for anything, they have some horrible ones for cars and other stuff. They had commercials for aspirin plus heroin. I didn't have room on the slide. But first generation antipsychotics. So, Thorazine, chlorpromazine starts off this work, and they start experimenting on that one chemical. And they're like, let's see if we change some stuff about it. Can we really come up with something better? Maybe something that's a little less sedating, something that doesn't give you a Parkinson's. And so the first generation antipsychotics we know now, we're just working on the dopamine, the D2 receptors in the brain. So what they did was they just quelled the positive symptoms of psychosis. They took away the hearing voices. They took away the delusions, the agitation. But as we all know, if we've talked to people with psychosis, there's a lot of negative symptoms. You'll get like catatonic patients, depressed, down, very low energy patients. It wasn't doing anything for those symptoms. So you often got very sedated. If you look at your old movies about the asylum, there's a bunch of people shuffling around, with no real joy in their life. And so they came very quickly right behind one another. After 1950, having Thorazine, you came with Prolixin within a decade, Haldol within a decade, which are still used. You got Loxapine in 75. That was the last one, pretty much of the typicals. You got, and some of these other ones that you might have heard, I still use ORAP every now and then for like movement disorders. The other ones are kind of like faded to the wayside, but so The movement disorders that we talked about were the extrapyramidal symptoms, right? You got akathisia. When a patient first starts an antipsychotic, you might notice that they're on a new medicine and they're sitting in your office for therapy and they can't sit still. They just stood up because someone stuck them on a really big dose of Abilify or something. And they can't sit still. And they're like, I just can't sit still. I can't sit still. Well, sit down and let's talk. I just can't. I can't sit still. I need to pace. I'm pacing all day long. That's akathisia. It's an inner restlessness. So if you notice that, tell them it's a side effect of medicine, go back and talk to the person prescribing it to you. You got, if you left them there in place, you got Parkinsonian symptoms. You got rigidity, tremor, postural instability. They just kind of fall. You see them kind of shuffle walking. You see tremors, just slowed movements. Or you get twisting repetitive movements, which goes into like tardive dyskinesia, which if you've left the medicine there too long, until recently, that was kind of a death sentence. You got tardive dyskinesia, which is involuntary repetitive body movement. What they'd be grimacing, sticking the tongue out, smacking their lips, rapid jerking movements, slow writhing movements. Like one of my first memories of like anything psychiatric as a child, my dad is a psychiatrist, he still kind of partially practices down in New Orleans, was going to this person's house. A friend of a friend had asked him to go see someone with psychiatric issues in the house to figure out what's going on. And so, for some reason, he had taken me along. I probably was like 8 or 9. And we walked into these people's house, and this guy's just like laying on the couch, and he's just nonstop moving, writhing, smacking his lips. It looked horribly uncomfortable. And when we left, my dad was like, yeah, like someone put him on really strong medicines, and they left him there on those medicines for a long time, and they were happy his delusions and psychosis were gone, but this is what happened from the medicine. And so I remember seeing that, and thankfully we don't see much of that now, because over the years we've realized it, we've stopped doing that to people. But if you've ever seen it, it's really horrible. Increased prolactin concentrations is another possible side effect. So dopamine kind of functions as, it's got a good balance with a hormone in our brains called prolactin. Normally, in women, prolactin elevates, you make breast milk out of having a baby so you can feed your baby. But for some reason, some of these antipsychotics were working on the wrong dopamine receptor, elevating prolactin greatly. You probably heard of like Risperdal, a decade or so ago, getting sued because they had a lot of gynecomastia going on. You still have patients you'll be like, well, let's try some Risperdal. I don't want breasts, male patients. So that was definitely a real thing with the first generation as well. So you can get all of those. You can have milk secretion and breast enlargement in men as well as women. Amenorrhea, their menses completely stop, dry up. Impotence in men, anorgasmia in women, like those are all possible side effects, not only with the first generation antipsychotics, but with other meds that we'll get into as well. Neuroleptic malignant syndrome is about the worst. I've seen one case in my training early. Thankfully, I haven't seen any, recently. But it's a rare but fatal adverse effect that happens at any time during the treatment with first-generation antipsychotics. We used to think if you gave them too much, it could happen, but we found that it can even happen with low doses if you just keep giving it and you're not looking out for the signs. You really want to watch for increased temperature, muscle rigidity, confusion, agitation, and elevation in their white blood cell count. And it's lethal. They can die from it. So then we get to the third, or the pre-modern era, which goes from the mid-1960s to the late 1980s. And they ended at the late 1980s because that's when Prozac comes around. And Prozac was considered a really big deal. During this time, because if you kind of take the theme from the early days of psychiatry, they were just experimenting people willy-nilly. They were like, I destroyed this part of the brain and it got better. So some other doctor would go, well, let me try that too. Here, open up your eyes. We're gonna take out your frontal lobe as well. But So they decided to come up with a randomized clinical trial where you have the people receiving the medicine, you have the controls who are receiving placebos, you have large amounts of people getting the same treatment. Thankfully, they weren't doing that with lobotomies, but when they came out with these medications, they came out with an ordered, reproducible mechanism of testing whether these medications work or not before just giving it to the random public. So, and all throughout this time, pretty much, because you had these asylums, that's who it was being tested on. So then they started coming out with some of these theories for neurotransmitters, like what makes it work? Like why are they behaving this way? What's this abnormal process coming from? And also during this time you got lithium. Like we think that lithium, like I thought, lithium was a long, long time ago, but it's fairly recent. We have some of us in here who were alive during this time. Me. So neurotransmitters, I'm going to not get into the details, but just basically going through the neurotransmitter theories that we have, they've been around for a while. So we still kind of follow these theories. We're making a little, alterations to it, giving it some thought, but they're still the best explanation that we have on why our medications work, why people have mental illness the way they do. And so we'll go over some of the basic ones. The catecholamines are what we call the monoamine neurotransmitters. You have your epinephrine, which is adrenaline, norepinephrine, which is noradrenaline, and dopamine. And those are synthesized by the adrenal glands above your kidney, and they make their way up to the brain. Serotonin, or 5-hydroxytryptamine, 5-HT, it's also a monoamine, but that one's produced for depression and psychiatric issues or mental health issues. That part of it's created in the CNS, but 90% of our serotonin is actually produced in our GI tract. And its purpose there is to regulate intestinal movements. And we'll talk about more why that's important later. Glutamate is the principal excitation neurotransmitter, and we're just starting to really get into the research on how do we use that, and we'll talk about that when we get to the meds. And then GABA is our primary neurotransmitter that calms us. Real quick diagram of, as we're going to be talking about the geography in our brain, there's 100 billion neurons in most of our brains. Some of us maybe not that many, but no, I'm just kidding. So there's 100 billion neurons in the human brain. So basically, you have your nerve cell up there. The message is going this way. It's originating from the centers, and you've got your axon coming down and touching a dendrite, which is the receiver in the next neuron. And in all of those little places, and if you look in the picture, like each neuron has tons of little dendrites and tons of little ends of the axon. So if you've got 100 billion neurons, you've probably got, I don't know, a trillion or more connections going on. And at each one of those little connections, some sort of this reaction is happening to pass on the message. You get a neurotransmitter of some sort that's produced, sent down, released into what we call the synaptic cleft, where the two are meeting the axon and the dendrite. Some of those chemicals, it just spews some of it go and they hit the dendrite, where they have receptors for that particular neurotransmitter, and it's transported in to pass the message. It's an imperfect scenario. Not everything secreted reaches the end. Not everything that's secreted is ever picked back up again. Some of it gets lost. I mean, at a very, very, like, micro doesn't even seem like the right word, but like, nano maybe level, like we have trillions and hundreds of trillions of these little things just making connections, and that's what makes us think with different neurotransmitters. That's what makes us move. That's acetylcholine. That's what makes us happy or sad or anxious. Like all of these little computations are happening in our brain, and we figured out some chemicals that can maybe adjust it a little bit, which I think is pretty amazing. And I just wanted to point out some of these things. So they have these little other enzymes in little processes in there. The reuptake inhibitor, reuptake transporter. So basically, after all these vesicles release these neurotransmitters, you got all this stuff laying around. What's going to happen? Well, some of them are going to connect to the receptors, and then once they pass on the message, they release. They've been spent. What happens to the spent ones? Well, they're taken back up, and because it's an imperfect process, not only are the ones that have been spent sucked back in, but a lot of the ones that were just floating around and never got to where they were supposed to get to, they get sucked back in too. You have these monoamine oxidase enzymes. That's my ugly purple drawn thing. I drew that in there. I was trying to do a Pac-Man thing, but I couldn't figure out how to do it. So you have different types of those. Those destroy the neurotransmitters, recycle, repackage them into the vesicles, so let's do it again. So those are some of the verbiage that we're going to be using on the next couple of slides. So with the monoamine theory, or what was called the catecholamine hypothesis of affective disorders in 1965, it was proposed based on observations that we got from these medications. So we got these medications not knowing what they did. We kind of derived our hypotheses based on what we thought these medicines that we were giving people were probably doing in the CNS. So they noticed that some of these monoamine oxidase inhibitors, and they knew what the MAOs were doing in a mammal brain because they would try it out in like rats or monkeys, and you know, you can't really test it in humans because you have to open up their skull and take samples and biopsies while they're still alive, and that nobody really wants to volunteer for that. So they were doing it in animals, and they noticed that the MAOI drugs, the monoamine oxidase, remember a little ugly Pac-Man? Inhibitor drugs, so they inhibit that. They increase the levels of norepinephrine or adrenaline and serotonin in the brain. And so the people had a little more energy because now they have a little more adrenaline in that space, and they were a little happier and less anxious because the serotonin increased in that space. That's what we think. And so they also noticed that because amphetamines were around by then, right? So the amphetamines, they released norepinephrine from neurons and they blocked its inactivation. So it just kept going. Acute administration of amphetamine caused a rebound depression. Like if you pushed it long enough, they got depressed, which made them think that maybe if we just refuse to take our foot off the gas pedal, we're just running out of gas, right? Kind of makes sense in hindsight. So they thought that was because of the depletion of the adrenaline. And then the tricyclics, they noticed, inhibited the reuptake of adrenaline into the neurons. So they were just like figuring this out using animal models and the symptoms that were happening in people as to why we think this medicine's doing what it's doing. So if it's doing it in people, this must be the abnormal pathology that's causing those abnormal symptoms to begin with. So just to give you a little background, the MAOIs, we don't use a lot of them. Selegiline, NSAM, we still kind of use sometimes. It comes in a patch form. It improves cognition, especially in like older folks. I haven't done geriatrics in a few years, but when I used to do a geriatric inpatient unit, if we couldn't sneak the medicines in the pudding, the NSAM comes in a patch. You can stick it right between their shoulder blades, and they couldn't reach it to take it off, and it helped. And it helped their mood when nothing else really did. The other three, I mean, you might have heard of them, Nardil, Parnate, but we don't really use them anymore. But these MAOIs had this horrible side effect, right? You couldn't have meat, processed meat, like hot dogs, salami, bologna, and what's a life without those, right? And then you couldn't have pickled food, you couldn't have soy sauce. We all just hear wine and cheese. You can't have wine and cheese. Well, you couldn't have like aged cheeses, like not those craft slices, but actual cheeses. You couldn't have any alcohol really because it would really cause a fatal reaction. And so really closely after the MAOIs, they came up with the tricyclics and everyone just kind of jumped. They were like, all right, well, at least we're not killing people who are going to wine and cheese tastings. And so with the tricyclics, you'll notice some of those meds we still use today. You have the Elavil, Doxepin, and then if you have some patients with like OCD or bedwetting, you'll notice imipramine. or nortriptyline. Like some of these meds are still used nowadays. But the negative was, you know, if my grandfather had been a psychiatrist and he was sitting in his office, he wasn't, he was a veterinarian. But if he was sitting in his office and he was seeing a patient who was really super depressed, you know, possibly suicidal, and he'd be like, got this new stuff for you, it's called a tricyclic. I know you're feeling really suicidal. Here's some medicine that'll help your depression, but if you take too much, it could also kill you. Wasn't perfect, right? I mean, there was still that kind of negative to it. But it was the best they had, so they did it, and they worked. Wanted to talk a little bit about what the symptoms, I mean, what these neurotransmitters do. So, you know, norepinephrine, which is just adrenaline, does exactly what you think. I mean, we've all seen, like, Crank, the movie, or, you know, like, if you have too much adrenaline, what happens? You get fight or flight stress response, you get energy arousal, you get arousal, concentration improves, you get hypervigilant, right? And I know those symptoms are reminding you of the stuff on the right side, but we'll connect it. Symptoms of imbalance: if you don't have enough norepinephrine in your body, if you don't have enough adrenaline in your brain, you're gonna have a lack of attention, you're gonna have a lack of focus, you're gonna have a lack of concentration, you're gonna have really low mood, you're gonna be depressed, you don't wanna get up or do anything, your body hurts, you know, your head hurts, you have pains all over, and in increased adrenaline, you'll have increased heart rate, tachycardia, and elevated blood pressure. So we've mentioned amphetamines a couple of times in the last couple of slides, so I thought we'd talk about them a little bit. So the amphetamines really came about in the late 1920s. The popular story goes that the Nazis wanted their pilots to stay awake for the flight and back. And so they would pump them full of the stuff that they had come up with called amphetamines to kind of keep them awake. So the amphetamines work in multiple ways. Methamphetamines, Adderall, I mean, any amphetamine is going to work the same way in that it pretty much does everything in the brain, like all of those various types of things that were going on in that synaptic cleft. So it's going to increase the release of the adrenaline and dopamine because it makes you feel good. That's why people use methamphetamines, because they're getting a lot of dopamine release. From the presynapse into the synaptic cleft, you're going to get blocked uptake. So that adrenaline is going to stay there until all of it's used up. You know, all of it's going to eventually get to the receptors. And it inhibits the monoamine oxidase. So no, we're not recycling it. We're just shoving it right back in there. So, and that's why you have that burnout. That's why you have that crash. That's why sometimes if you have you know, patients with ADHD who are on an amphetamine, they're like, I just totally have a crash. You know, 4 or 5 o'clock, I'm done. My kid is so cranky when he comes home from school. Well, you've just been like doing everything you can to force as much adrenaline into the synapses as possible, and now your car's out of gas. Serotonin, 5-hydroxytryptamine or 5-HT. There's lots of different subtypes of these. So you'll see some places there's like 5-HT, 1, 2, 3, 4, 5, 6. There's lots of them. Different ones work in different parts of the body. And that's why like you get side effects when you do from SSRIs, because we have it in our pleasure areas, we have it in our GI, may cause nausea, vomiting, diarrhea, constipation, right? Because we have most of our serotonin receptors are in our GI system. But also, when someone's super anxious, you know, it's like, I'm anxious, I gotta go to the bathroom, you know? Or I think I'm gonna throw up, a little kid, I can't go to school, my tummy hurts. All valid, explainable symptoms due to serotonin being there. So, symptoms of imbalance, when it's not being in the right amounts, you're gonna get worry, anxiety, self-criticism, obsessive thoughts, insomnia, and low self-confidence. And this is just another version of that synapse that we had talked about before. This is just with the serotonin coming down through the vesicles, you know, being transported here, being thrown down into the receptors. Some of the receptors catch them, some of them don't. You get the reuptake back in here, the MAO, you know, recycles it again, repackaged, released, and so our drugs just basically hit various areas of those receptors, we believe. Dopamine. involved with reward and pleasure, mental alertness, appetite, and motivation. That's why some people get a dopamine release from eating, right? I mean, it makes you feel good. Dopamine gets released. Some people get it from, if they want abnormal levels, they're using narcotics or alcohol or sex or all the things that make them feel happy. So symptoms of imbalance are going to be, you're going to have lack of pleasure or apathy. You're going to have low motivation, procrastination, mental fatigue, low libido, restless legs. The dopamine hypothesis of schizophrenia, because that's where not only is dopamine involved in depression, but it's also an excitation, a relative excess of dopamine production and usage in certain areas of our brain causes psychosis. And they also learned that from looking at drugs that would decrease dopamine activity, right? Thorazine and Haldol. And drugs that would increase dopamine, like amphetamines. And if you took too many amphetamines for you, you would get a psychotic agitation. So they were like, if Haldol and Thorazine, we know deplete Thorazine, make you be less psychotic and cause these symptoms, and amphetamines are causing increase, so they were kind of able to map out what dopamine would do in the body, in the brain. Essentially, it came about when Thorazine and related drugs were noted to cause symptoms similar to Parkinson's disease, and that's how they were able to get some more of the symptoms, or the functions of dopamine. So then we get to the modern era, and it's sad when I sometimes think some of y'all weren't even alive then. I'm getting old. So Prozac was launched in the US in 1988. We got somewhere earlier than that era the launching of clozapine, but it really didn't pick up until this era. And then we'll talk about some of the newer therapies. But Prozac was a big deal because, remember how my grandfather was sitting with a patient and he was like, here's some pills that'll make you feel better, but you can also use it to kill yourself? Well, you couldn't do that with Prozac anymore. Because, I mean, technically, I guess, rarely it's possible, but you know, just to dissuade my patient from trying, I'll sometimes, if we have good rapport, say, listen, here's an SSRI. And they're named, you know, they're worried, what's it gonna do to me? You know, is it potentially dangerous? I'm like, the only way this will kill you is if you pick up like a 90-day supply, swallow the whole thing, vomit, choke, and aspirate on it. It might be a little bit of an exaggeration, but they were very, very serious side effect free. And so that's why it was really a huge deal. So look at this side of the slide first. I couldn't fit that here. So the SSRIs, they started coming around, and they're kind of broken into the ones we try more often, the ones we try less often. Celexa citalopram used to be like very commonly used because it was one of the first ones that came around after Prozac. But the FDA a few years ago came out with caution that if you gave older folks, they say 60 and above, I'm just not going to take that risk with younger people because you never know what's going on with their heart, that you really shouldn't prescribe more than 20 milligrams a day because it can cause QT prolongation, which can cause a fatal arrhythmia in people if you've used it for a long time at high doses for, you know, for years and years and years. They noticed a slight uptick, and so they gave caution. Go ahead.
Is that serotonin syndrome?
No, this was different. This is QT prolongation. A lot of the antipsychotics can do that too, but citalopram, a lot of the psych drugs can do it. So basically what happens is, if you've ever seen an EKG, like some of it's stretched out. So when it stretches out, just imagine like when you're, you know, you see kids chewing gum and they pull the gum out, what happens the longer you pull it out, it starts falling apart. So the heart rhythm kind of happens too. When you start like stretching out to the point, it twists, and the EKG is basically a reflection of what our heart function's doing, and if it's beating out of order, you've got an arrhythmia and you'll die because your heart's not reaching where it's supposed to reach when it's supposed to reach. So it's one of those serious side effects that can happen. It's not hugely common, but a lot of us have just, we're like, you know what, we have so many other SSRIs, why are we gonna push our luck and have the one patient that this happens to? So I, for one, like if someone comes to me on more than 20, I'll give them the choice, look, either we're going back down to 20 for your own good, or let's just try another SSRI. Because you still have a lot of people running out there, and older folks too sometimes, because not everybody knows about this, but you know, so I'll get patients that are like 40. I've seen recently a OCD patient who, you know, had an older prescriber who had them on 60 of Celexa. Like, it's just not a good idea. Let's try something else. But you know, like these are some of the benefits of the SSRI, or like the strong points of the SSRIs, was that with Prozac's super long acting. Like it stays in your body. They even have like a weekly variety where you can just take it once a week, which I would never remember to take, so I don't ever prescribe that one. But Prozac has, because it's so long acting, it doesn't have a withdrawal. Like when I have patients and we decided, you know, Prozac's not working for you, let's try something else, there's really no need to taper it off. Like it's got such a long half-life that you're, the amount in your body just kind of slowly just falls off by itself. So that's a good one for people who just like frequently jump off of meds, and you're not gonna have to worry about you know, them having withdrawal symptoms or discontinuation syndrome, like we like to call it. Zoloft, when it came out, was amazing because it's really, really great for like social anxiety, and over the years, we've found that it's safe in pregnancy, it's safe in breastfeeding. And so that's one of the ones that if I have a young female of reproductive age and she's worried about, you know, in a couple of years I'd like to get pregnant, you know, engaged, I'm gonna get married, I'm like, look, Zoloft's kind of a no-brainer in this spot. Let's see if it works first, because we're not gonna have to worry about taking it off when you're pregnant. Because at the end of the day, you know, it's not healthy for the baby, for the mother to be severely anxious and depressed and not taking care of herself either. So we want to find stuff that, you know, first do no harm, but let's see if we can help things a little bit. So, and then you have some of the other ones like Luvox. I still use somewhat for like OCD if I failed, like Prozac and Zoloft. There's a lot of drug interactions with that, so you kind of have to know what you're doing, because if they're on any other meds for any other medical issues, like there's this whole enzyme system in our liver called the cytochrome P450 system, and it's kind of, I describe it to my patients as a highway, a super highway of stuff that has to get metabolized through the liver first, and if like each type of CYP is a lane, and certain drugs can only go through certain lanes, like that's their lane. They have to stay in their lane to get metabolized, to get activated so that they can cross the blood-brain barrier and work. So if there's a breakdown in one lane, if there's another drug occupying and hogging up that lane and going super slow on the interstate, there's no option to switch lanes and go around. The action of that drug is going to be affected. And there's some psych drugs that really do that. Prozac does it to a few of the cytochrome P450 systems. Luvox does it to like three of the lanes. And then Paxil also, you get a lot of sexual dysfunction, weight gain, people feel slowed down. There's a high risk of birth defects with that one. It also has strong liver enzyme interactions. But I still use it sometimes in people with like severe anxiety, panic. Sometimes it's the medicine that works for them. So you just have to be careful with it. All of these can cause sexual dysfunction. All of these can cause weight gain. And so there was a push in more recent years to let's come up with stuff that doesn't take away your orgasm, because how are you going to be happy? So they came out with some of these newer medicines, and they're not technically SSRIs. They work slightly different ways. One of the newer ones is vilazodone. It's actually gone generic now. It was with the commercial name Vibrid. It basically works like an SSRI and a partial agonist at one of the receptors, kind of like what Buspar does. But Buspar is very short acting. This one kind of combines it, so you have no weight gain and no sexual side effects with that one. Works pretty good. I've been introducing it more if people have, you know, with the first lines, if they're having sexual side effects or weight gain, I usually switch them over. There's also Trintellix, which is still name brand. It's a combined SSRI, same as the other one, but it also has a couple of other antagonisms, and it works well for some people too. And then I talked about Buspar. A lot of people use that kind of incorrectly. It's got a very short half-life, and so, someone will be like, oh, just when I get anxious, I pop a Buspar. It's probably placebo effect. You really have to take it like 3-4 times a day for it to really work well. Atypical antidepressants. So these are the other ones that aren't SSRIs, they're not tricyclics, they're not MAOIs, they're not the newer serotonin drugs, but they're ones that you've heard of. So the easiest one that we can class, because we've got 3 of them, is the SNRIs. So remember, SRIs were selectively serotonin, SNRI are serotonin and norepinephrine or adrenaline. So not only do they do some of the serotonin effect, but they do some of the adrenaline effect, which is giving you a little energy motivation, getting you brightened up, and usually doesn't make you gain weight, usually doesn't make you have sexual side effects. And so very, very popular, lots of people are prescribed it. When it first came out, they came out with the regular Effexor, not the Effexor XR. Because remember, all of our serotonin receptors, it hit a lot of them, and so when it first came out, it was causing horrible GI distress, and people were calling it side effects or almost killed the drug, which would have been a shame because it really is a good medicine, but they were able to formulate it in an XR way and relaunched it to get rid of a lot of those GI upset issues, and it's been a great option. The other SNRIs, with repackaging it and coming out with the XR form, people were still scared. I remember when I was in training, I had certain attendings who would be like, oh, don't prescribe that at all. The patient's gonna come back saying they feel horrible, even though it was the XR now. They were afraid to try it. They weren't gonna try it. A lot of doctors, they were like, hell no. If XR was so bad, I'm not gonna try this XR crap, it's gonna do the same thing. So like my attendings wouldn't use it. Like when we were doing SNRIs, they would only use Cymbalta, which also had GI issues, but they were more comfortable with it because I guess it was less frequent and less severe. And it's funny because now like it's completely opposite for me almost. Like I don't use a lot of Cymbalta because of the GI issues, but I use a lot of Effexor XR. But they're, drug companies will drug company, right? So they were like, we didn't make enough money off of this Effexor XR. So they decided to go find the active metabolite, the part that actually works in the Effexor, and Effexor is venlafaxine, so they came out with desvenlafaxine, which was new, improved, and way better, and they launched that, and it was super expensive, and because it was a pro-drug, it didn't have to go through any of those highways in the liver. It just bypassed it and was able to go straight to the brain after being absorbed through the intestines. So really and truly, the only ones who really need to be on desvenlafaxine or Prestige is people that are on a lot of other meds. You're trying to avoid the congestion on the interstate, and you're, like older folks particularly, because they're going to be on more meds because you get, another pill added every day after 65, every birthday after 65 or something. So Prestige, it's generic now, desvenlafaxine. So, and then of course Cymbalta, and they kind of work the same. Cymbalta got, a lot of these drugs get FDA approval, meaning that they do these trials for a certain thing, and if they can show some evidence that it's helping, they get FDA approval for it, and then the insurance will cover it based upon that approval. So there's a lot of medicines that might do a lot of other stuff, but they never went and got the FDA approval for it. And so sometimes doctors don't use those drugs for those things even though they work. So basically, I've found in my clinical experience that any of the SNRIs are going to help with stuff like fibromyalgia. Like, oh, this person has chronic neuropathic pain. We should just give them Cymbalta. No, you're going to actually give them the Effexor, Prestige. They all work kind of the same in that class. But Cymbalta, you go to a primary care doctor or a rheumatologist for mystery aches and pains, you're getting some Cymbalta first. And then Wellbutrin. Wellbutrin's got a really interesting history that I'm going to do on the next slide. Like I love that story because it's so funny because it goes back and forth. But some of these other meds, mirtazapine, Remeron, you hear it a lot. It's an atypical, not tricyclic, but tetracyclic antidepressant. We give it at night. Works great for nighttime anxiety, but it gives you the munchies really bad. So people that need a little extra calories, I'll give them that. If they're not worried about the weight and they're healthy, I'll give them that. But we watch out to make sure we're not giving them other medical issues like diabetes. Nefazodone, you're not really seeing it anymore. They had a shortage a few years ago. I had a bunch of people that had been on Nefazodone come inpatient to try and find something else that worked. They had just come up with it because Trazodone worked so well for sleep, and they were like, it is an antidepressant, it's kind of a weak antidepressant by itself. What if we figured out a way to make Trazodone be less sleep-inducing? And they had come up with Nefazodone, but you really don't see it much anymore. It was a good medicine. So the Wellbutrin story, which is really interesting, they actually created it in 1969. The US patent was granted in 1974, but it wasn't given FDA approval until 1985. Originally, the drug company said, let's give people 400 to 600 milligrams because that's what makes them better. But all of a sudden, a lot of people started having seizures. And so the government pulled it and said, you can't sell this drug here. We're having people having seizures left and right. So they withdrew it within a year because literally like the approval date in 1985 was like December 30th. They caught someone on vacation to approve it, I guess. Now that was regular bupropion, regular Wellbutrin, not SR, not XL. And so they studied it, figured out like what can we do to prevent this from happening, because in the people that didn't have seizures, it really did help with depression because it worked on their adrenaline and dopamine. It had no serotonin action. So it just helped with the other pathways that would improve your mood. So then they reintroduced it in 1989, saying that, look, just keep it to 450 and below, and you should be fine. But of course, then the patent runs out, right? And they can't make any money off of it because the generics come out. So in 1996, they come out with the sustained release, which was dosed twice a day, not at night, because it's an adrenaline medicine. Remember, no adrenaline medicines at night. Sometimes people come in saying, my sleep is horrible. How do you take your Wellbutrin? I can't ever remember to take medicines in the morning because I take all my meds at night. Well, you're taking an adrenaline medicine at bedtime. Of course you're not sleeping. Of course you're having crazy dreams. Let's move it to the morning, and they're like, so much better. Yes, you are. I'm not kidding. Like I've had at least 3 of those in the last 2 months. Just dosed at night for some reason. 2003, they came out with the extended release, the Wellbutrin XL. In the middle of that, they realized that it was making people quit smoking. Like, not only were they happier, but they weren't smoking anymore. So they launched the same drug, different name, Zyban, and said it's just for smoking cessation. And then again, in between all this, they actually had these crazy lawsuits that happened. Some consumer protection companies pulled and experimented on all the generic forms of Wellbutrin that had come out, and I think this was in England. They presented data that the Wellbutrin generics do not work as well as the name brand. And so the company was like, all right, we're gonna relaunch the name brand and try to see if we can get a push for people to prescribe name brand. But our health insurance companies weren't having it. They're like, we're not paying for the expensive stuff, we're paying for the cheap stuff. And so some company decided regular Wellbutrin is bupropion hydrochloride. So they took the hydrochloride, which is just waste filler, they changed it with hydrobromide, and they came out with a brand new antidepressant called Aplenzin. It's just basically name brand Wellbutrin. This is one drug in which, just based upon tons of patient reports, there's absolutely a difference between name brand and generic Wellbutrin. Doesn't matter what generic you get. Like I have literally seen patients perk up because Wellbutrin also decided to start sampling it again. So I switched some of my patients. I was like, I don't know what else to do. We've tried everything. You're kind of good, but you're not all the way. Let's just try the name brand samples that I have. I'm gonna give you like a month worth of samples. Take this. They show back up and they're like, this is different. I feel so much better. And it's like, yeah, but your insurance company's not gonna pay the $1,000 a month for name brand Wellbutrin. So a couple of those I've switched over to Aplenzin because it's name brand bupropion, right? It's pure and stronger. It's just some side stories. We talked about that already on the other one. So new agents. So they came out recently, and if you listen to the drug companies, every new pharmaceutical agent that they launch is absolutely like, industry changing, history making, it's another Prozac, we're gonna have a fifth era. But this one, there's one called Auvelity that I have there listed on the left side. It actually doesn't work like any of the other antidepressants. It works on the NMDA receptors going through the glutamate channels. I didn't even talk about it because I'm not great at it. I don't know exactly how it works in the brain. But it works on a whole completely different pathway that, they were using some of these hallucinogens and stuff that they keep researching. So basically what happened was they were trying to get approval for stuff like, ketamine or some of these other LSD, sissy, and the government just won't approve it for like widespread usage. They keep having research in little pockets in like Colorado and Seattle, but like Pennington was trying to do one and it never got approved, and shrooms and stuff like that. So they're like, what other agents do we already have that kind of work on that brain? And if any of y'all had the misfortune of knowing some wayward youth when you were growing up, some people would take like a bottle of Robitussin DM and just drink the whole damn thing and go robo-tripping, right? Well, it wasn't the cough syrup part, it was the dextromethorphan in it that gave them really brief trips and then went away because it's rapidly metabolized in the brain. It's kind of touch and go if you just take a little bit, but it's punch and go if you drink the whole bottle. And so they were like, how do we make that little effect be not so severe, just kind of prolong it? So remember we talked about all the highways in the liver with the cytochrome P450 system with all those different lanes. So they were like, dextromethorphan, what lane does it always stick to? And then what other substances, there's some smart people out there that come up with this stuff, but what other drugs go through that same highway that we can use it to clog it up, cause a traffic jam, and make dextromethorphan stick around? And they found that Prozac and Wellbutrin were the two that went through that same 2D6 lane in the liver, causing it to prolong and act. So when they gave it, they saw like this rapid, different way of making people's depression better. Now, I had read the research a couple of years ago before it ever launched, and I was like, well, that's interesting, let's try it. So I had like this really suicidal, like he had suicidal thoughts, but he wasn't gonna kill himself, kid I was seeing. I was like, well, this drug's not out yet. We've tried some other stuff. I was like, the data was really good. Like the trials were pretty amazing. Like people really got better. Their depression really, most of their symptoms alleviated. So I was like, this is what we're gonna do. You're gonna go out and buy some Delsin tablets, which are dextromethorphan. They come in 45 milligrams or 15 milligrams. You're gonna take 3 of those, and you're gonna take a Wellbutrin, because in Auvelity it's like 45 milligrams of dextromethorphan and 105 milligrams of Wellbutrin. I was like, I'll give you a SR 100. Take both of these for a week and come back and tell me what happened. Nothing happened. I tried it in a bunch of patients. So the way they made the tablets, it's like I've had other doctors who, like I would start someone on Auvelity, they start them, the insurance companies are fighting us on it, PAs aren't going through, so they're like, well, they tried to do the thing I did too, and I was like it's not gonna work. They have it set up so it like releases at the perfect ratio or something, and like just a few things doesn't work. But it's a pretty good medicine, like it's been working in some of the patients that I haven't been able to help with other stuff, but it is expensive. So for the treatment of postpartum depression, they came out with this 2 new stuff. I have not used either because I don't know how I'm gonna get that approved for a patient, but so it's basically for the initial treatment of postpartum depression. Someone's just had a baby and they're severely depressed. They've come out with Zulresso initially, which is brexanolone. They basically took a normally occurring derivative of progesterone that in most women it's released from their brain to make them happy and have those maternal bonding feelings with their baby. And they synthesized it basically, and they give it in a 60-hour infusion. So they just bag after bag of IVs, and it goes through your system. But you have like, supposedly postpartum women have like this remarkable turnaround improvement in depression. I've met one patient who had it before, but like I've never prescribed it, but it's $34,000 for the single treatment. So then, I think maybe the same company, they're like, they couldn't do the pill initially because your gastric acid was just destroying it. It wasn't making it to where it needed to go in the brain, but somehow they got around that, they figured it out, and they came out with Zurzuvae, I think that's how you pronounce it, which is zuranolone, in 2023, so just last year, and it's a 14-day oral course of a similar compound. That just costs $16,000. So I haven't prescribed it either. Other treatment options for depression. Some of you may have had patients that have gone through transcranial magnetic stimulation. It's interesting, when none of my medicines are working completely the way they're supposed to, I'll sometimes refer someone to go get TMS. It's a prolonged course. The way it works is that you get these brief magnetic pulses that stimulate neurons in the prefrontal cortex. It's kind of cool how they map you out when you go for the first time. You sit in the chair and they hit you with this electromagnetic pulse, really low frequency, kind of like an MRI, and they hit you on, they find like the motor section of your brain, and so your finger or your thumb twitch, and then they move it up just a little more because they know, like most people, the prefrontal cortex, the sensory area, or the mood area is right in front of it, and they repeatedly hit you with just short bursts for, you go in like 3 times a week or 5 times a week maybe initially for like 8 weeks. And there's data that it helps. The chairs cost like $90,000, so I don't have one. I think Our Lady of the Lake is the only one up here doing it. I think Dr. Harvey does. So that was approved back in 2008, so it's been around. So it's basically, when you pass on the message one, it passes all the way down. It's like, you gotta keep doing it because it's kind of like, it passes the message on. If you've ever seen those people standing in a line and one person says a word and then they pass it on. So to get it right, you gotta do it so many times that it needs to get to like the limbic system, activate it, and keep it activating. And so that's why it just takes repeated, prompting. We talked about the antipsychotics, and we haven't talked about the antipsychotics since we talked about Thorazine like an hour ago. I think, right? No. And so the atypical antipsychotics, so it was kind of interesting. So they took clozapine, actually came out like in the 70s, but when they were giving it to people, they had like some deadly side effects in like Finland, I think, where they had a whole bunch of people die from like the cells that create their white blood cell count completely disappeared. It killed them off, and so they went through what's called an aplastic crisis, and they died because they had no defense system in their body, no white blood cells. And so it was kind of halted, pulled. Everyone's like, I don't know about this. But what they had found fascinating when they were testing it the first time was with clozapine, they got 0 of the motor side effects. They got no akathisia, they got no Parkinsonian issues, they got no extrapyramidal symptoms. And so in the late 60s or 70s when they were testing it out, they were like, the language of the time was, that's atypical. Like, that's not usually what happens. It's not like they were calling Haldol, Thorazine, Prolix and all that typicals. They weren't. That was just your regular antipsychotics at the time. But they were like, this is really atypical. But let's put it aside because it doesn't make sense. Because in their brain, in the thinking of the time, you had to have the movement disorder to hit the dopamine centers to get the antipsychotic effect. Like, if you weren't hitting the dopamine centers, you probably weren't going to fix the psychosis. So even if in their initial trials, they saw that clozapine was helping with psychosis, they said, but it can't, because it's not causing Parkinsonism. So they kind of put it aside, they kind of got kicked around, and then they finally decided to come up with it again. But, so what happens is, during that time, the other drug companies take clozapine and they're like, well, that one's not that popular, it's got these issues. Let's see if we can synthesize other drugs kind of similar in chemical nature, and get them approved to see if they help with psychosis. So the first one that comes out was Risperdal. So when Risperdal was coming out, like whoever was doing the approvals at the FDA or whatever, they were like, well, since it's kind of like clozapine, let's call it atypical. People launching Risperdal, I think it was Janssen or Johnson, they loved it because they wanted it to be different. They wanted the assumption to be that it wasn't going to cause any movement disorders, that it wasn't going to cause Parkinsonism. And so they ran with the atypical label. They were like, yes, we're an atypical antipsychotic. Trying to link themselves up with the benefits of the clozapine, but we quickly learned that all of these can, less likely, but can cause all of those movement disorders. So you can have someone on Risperdal or Geodon or any of these other ones actually have akathisia. You can actually have them have extrapyramidal symptoms. You can have them eventually develop tardive dyskinesia, but that label stuck, that they were second generation, they're atypical antipsychotics, they're not going to cause it, but they do. So still to this day, clozapine is the only one. Like, so if you get someone that's super psychotic and is developing any of those activities, like I've got a young patient who's a college student, no matter what I give him at the lowest dose, he starts having akathisia, he can't sit still. We've tried like microdosing, Risperdal or Zyprexa is usually one of the least likely, Seroquel is one of the least likely, because Seroquel is actually chemically the closest related to clozapine. And so, young kid, and he got hospitalized a couple of times, and I was like, we just need to go Clozaril on him, and he's been doing fine. But the problem with the Clozaril is, when they finally got to relaunch it, the federal government put all these regulations in place for it. There's this REMS system, where you have to, when you first start clozapine on a patient, they have to get weekly white blood cell draws, and then after they've been on it for like 6 months, you can go up to like monthly. You have to submit it, you or the pharmacy have to submit the lab into that REMS system. It's like a registry, and then only then are they dispensed the clozapine. So it's a little bit of a headache. A lot of doctors in the US, and the US is the only place that has the REMS system. Much of the rest of the world has decided any of these drugs can actually cause agranular psychosis. Any of them can cause an aplastic crisis. They're less likely, clozapine is more likely, but they're like, let's let the doctors be responsible and actually check labs regularly. But in the US, there's huge regulations, so a lot of doctors just won't do it. I have a few patients on it. I mean, it's kind of like you've gotten termed the antipsychotic of last resort, but it's, aside from the excessive sedation, like it's very sleep-inducing, kind of like Seroquel, its closest cousin, it's an excellent antipsychotic. Like when nothing else works, that it should be tried. The regs on paper actually say if they failed 2 antipsychotic trials, you should do clozapine, but a lot of doctors just won't do it because of the headache with the labs. Like, this person's never gonna go get labs. Well, if they're not gonna go get labs, they're not gonna get medicine. But it works for like the ones with like a lot of family support, or the higher functioning ones who want to get better and not have psychosis. It's a really good antipsychotic. Side effects, adverse events continued, I think. So the biggest issue with the atypical antipsychotics is metabolic syndrome for most of them. There are some antipsychotics that do not cause this. Metabolic syndrome is a cluster of symptoms that there's other drugs, even non-psychiatric, can do it, which are weight gain, elevated blood sugars, hyperlipidemia, that's cholesterol going up, blood pressure increases. So you get this cluster of symptoms, and we've all probably seen patients get put on an atypical antipsychotic, and they gain a lot of weight, they start ballooning, they're like, I feel like I have to eat a lot. Or there's some that say, I feel like I'm not eating anything, but I put on 30 pounds. Well, you're eating something, you're probably just eating unhealthier, because it causes carb cravings. So some of them, like, Zyprexa is pretty much the most notorious, like will cause you, olanzapine will cause patients to put on a fantastic amount of weight. Like, I actually talk for a newer form, like when I said I talk for alchemies, there's a newer form of Zyprexa that offers like less weight gain. But I was talking to my sister, she's an oncologist, and I was like, she was like, what are you talking for? Because I don't really talk for pharma. I was like, it's this new drug that's an old drug with less side effects. I was like, so it's kind of easy to do that. And she was like, what is it? I said, well, it's Zyprexa, olanzapine plus like weight blocker. And she was like, why would you do that? Because in oncology, they love Zyprexa because they get all these patients that have cancer and can't eat. They put them on Zyprexa and it makes them eat. Like it actually keeps some weight on, keeps some strength on. So, you know, people will turn any negative into a positive, and that's great. But Seroquel can also cause a lot of weight gain, very sedating. We usually just dose it at night. Geodon had another interesting, like I love how these drug companies play with each other. So when Geodon came out, they had a couple of, remember how I talked about that, the twisting of the points on the EKG, the QTC interval? Torsade de pointe or something, I don't speak French. But that's what they call it, where you have like these massive arrhythmias and you die. Well, Geodon had a couple of cases early on, and then Seroquel ran around telling everyone, oh yeah, don't prescribe that Geodon because it causes arrhythmias and you'll die. So Geodon was actually weight neutral, but like a lot of doctors were like, oh hell no, I'm not doing EKGs in my office, I'm a psychiatrist, I'm not sending them for an EKG, that's too much trouble. But actually, any of the atypicals can cause that. Probably a lot less, but Geodon kind of got taken out at the knees right at the beginning. But it had to be dosed twice daily. It caused a lot of some of the other stuff like dry mouth. And so you'll see patients on it sometimes, but not a lot. Abilify, you know, Abilify is the modern day Windex where you can do it for everything. But you know, it is interesting because, you know, people are like, well, I use it for depression, I use it for psychosis, I use it for bipolar, there's a long-acting injectable, you can give it to schizophrenic. But it's hard to use for most people because it all depends on how much of it you're prescribing somebody. So if you're trying to treat depression, just unipolar, regular, major depression, it has to be at the low doses. It has to be just at like the 2, maybe the 5. You go up any higher and you start getting a lot of the sedation, the weight gain, and a lot of people that prescribe medicines are used to more is better. And so, oh, you felt a little better on 2, here, let's give you 5. You felt a little better on 5, let's give you 10, and all of a sudden they tank again. They're having more of the weight gain, they're slowed down because at that dose you're approaching antipsychotic dosing. And a lot of the antipsychotics can do that. Like if you give a little smidge of it, it'll activate dopamine a little bit, and it'll activate norepinephrine a little bit. You give a higher dose and it just suppresses the dopamine, like an antipsychotic is supposed to do. So then, you know, you had some of these other ones. Everyone's heard of that Invega because they have a shot. It was like, I remember when I was in training, we didn't have Invega initially, we had Risperdal. Risperdal, if you read the little insert, it had a mechanism of action of like 18 to 20 hours half-life. Same company comes out with Invega. Oh, Invega is once a day dosing because it has 22-hour half-life. And now all of a sudden the Risperdal inserts had 12-hour half-life. Like it literally changed in front of our eyes because the newer drug was better. And then Latuda is actually weight neutral. That came out in 2010. It's now generic, which is really good. You gotta take it with food. It's weight neutral, but you gotta take it with food. Some of these drugs require food to get absorbed. And then some of the newer ones, you know, are being used a lot for a lot of different things. They go to the FDA, they run trials, they get approved for bipolar depression, now approved for mixed state. You know, like they come up to you every week with another one. That's all about the antipsychotics. We talked about that stuff already in there. Elevated prolactin, Risperdal, paliperidone are probably the worst. They can still cause movement disorders. So actually, you know how we were talking about tardive dyskinesia and the side effects? So for decades now, you got tardive dyskinesia and you were screwed, it was over. Like, you know, we would have to take you off the antipsychotics so you could be psychotic, or you were just gonna suffer with these movement disorders, horribly not being able to sit still, your tongue and mouth moving all sorts of weird ways. But they came out with 2 drugs, and they really do work. Like if you know, they will at least reduce those side effects of tardive dyskinesia greatly. But I've had a couple of cases, like, you know, patients moving in from somewhere else were being treated with high doses of antipsychotics, had horrible tardive dyskinesia. I don't see those very often because I don't work at Jackson. I don't have a lot of the acutely chronic psychotic patients in my practice, but I tried these on a couple of patients and it's really pretty amazing. Like, it's nice to see a drug do what it's supposed to do. And then I briefly touched on the long-acting injectables. We've had them for a while. Even in the long-acting injectables for the typical drugs, you have the Haldol D and the Prolixin D, but these are the atypicals came out with, and they keep getting like progressively longer acting, right? So you got Risperdal Consta came out first, and it was 2 weeks, and then you got Invega Sustenna came out, and it was like 28 days, and then they came out with one that lasted 3 months, and they called it Trinza. And then this is my absolute least favorite drug name there is. They came out with a 6-month version, and they called it half a year. Somebody got paid for that. So that's my least favorite drug name. Then they came out recently. They came out with some subdermal, like subcutaneous. Like you pick up the skin and you inject some Risperdal in there, Uzedy and Perseris. Some of these drugs, like, I don't use them a lot because, when you discharge them from the hospital, then you get like this letter from the insurance company or the pharmacy saying it's denied. Do a prior authorization form, and you do the prior authorization form. It's like, no, it's still denied. And so I've been slow to take up some of these, but this Uzedy one, it actually, like, within 72 hours, like, you're on a full dose of Risperdal, and supposedly from some other doctors who are using it more than it does seem to work. But of course, you're going to have all those side effects from Risperdal potentially that you have to look out for. And then Abilify has 2 different ones because when aripiprazole went generic, another company made Aristada. That one's a month long. Abilify Maintain is a month. They have Asymptify, which is, I think, 2 months. And those are important because what do our patients do? Like, they don't take their meds, right? Some of these shots are approved for bipolar disorder. All of them are approved for schizophrenia. That population is notorious for not wanting to take the medicines. So I know I don't sound super enthusiastic, but I love these. I mean, they're like, I want to keep these people out of the hospital. Like, I don't want to see the same person back in the hospital every 6 weeks because they didn't take their shot the next month or didn't get a refill on the prescription, didn't make their doctor's appointment. We have like almost a whole industry behind chasing patients down, right? They have ACT teams and IOPs, and like we have all this stuff just trying to get patients to comply with treatment. So even though I hate Hafyera, I'd love if they came out with a whole Eura, or a whole Lifa. I don't know, so mood stabilizers, treating bipolar disorder. We didn't touch on the mood stabilizers. The part of this that I kind of wanted to talk about was the diagnosis of bipolar disorder. I know I touched on it last year too, if y'all were here, but the actual lifetime prevalence rate for bipolar disorder, can y'all read this number in the back? It's a 5. So in the US, it's less than 5%. Lifetime prevalence of bipolar disorder in the whole world, but the US, we're the highest. And this is honestly probably just like selection bias, they're not diagnosing it. But if we're diagnosing it right, 5%. Now, out of our patients, what percent of patients do we hear that say, I have bipolar disorder? I must have like half the bipolar patients in the whole United States. So I used to joke, like when I would first start out my career, and I used to work in the women's penitentiary at LCIW the first couple of years out of training as a part-time gig. Everybody there was diagnosed bipolar disorder. All of the women were diagnosed, like almost all of them. They were all on Risperdal and Depakote. And so you sit down and you talk to them, and I realized really quickly it's not very popular to have the borderline personality talk with the patient, right? Like a lot of these patients are diagnosed bipolar, and you're sitting there thinking, well, you must have like ultra rapid fast cycling bipolar disorder because your mood is up here 1 second, down here the next. I'm bipolar. No, you don't. You have a cluster B personality disorder. And so that little nature versus nurture talk, the importance of therapy talk is important, but doctors don't like having it because, so you're telling me you can't fix this with a pill? No, I mean, we can lengthen your fuse by decreasing your anxiety, but no, we can't fix your borderline personality with a pill. You're gonna have to go to therapy, and good therapy. So that was just my little pet peeve, so I came up with that. I mean, that's why this slide's here, no other reason. When we get to the mood stabilizers, lithium. Lithium is actually on the elemental table. Supposedly it's one of the first 3, I don't know who was there to tell us about it, but it was one of the first 3 elements invented in the Big Bang, right? You had hydrogen, helium, and lithium. So lithium was around naturally for centuries, but no one really started using it. Well, certainly not in the US, and the doctors had to fight for it in 1970. 5 minutes? Oh, let's hurry up and get it done now. I want y'all to ask me questions. So we'll skip over the mood stabilizers. Lithium's really cool. This story was kind of cool. They had this guy, he was working in a silo. He probably went a little nuts himself because it was during the war. He was in Singapore in a little insane asylum. He started taking his patient's pee and injecting it into guinea pigs, and he would see what would fix their acting out or dying. And he found that lithium, which they used to use for gout, actually seemed to make them better. So he published it. Nobody believed him. One doctor in a Danish psychiatrist decided to try using it again, cured his brother, or treated his brother successfully for bipolar disorder, and that's when it came about. And in the US in 1970, it was approved for bipolar disorder. These are some of the other ones. Lamictal is great. This one's pretty bad because of, but if they're sick, it works. But in the US, there was a concerted effort to pitch this and not the lithium, scaring doctors at lithium levels, kidneys, thyroids, all that good stuff. We use all those second generation atypical antipsychotics for bipolar disorder. You have the serotonin hypothesis, which was actually around since 1967, but some of the other drugs that we have, benzodiazepines, they're really addictive, don't leave people on it for a long period of time. They work fine for 2 to 4 weeks. We get a lot of people stuck on it for a long time. Not really great. You have all these other benzos. Benzo-like is Ambien, Sonata, Lunesta. They're still not great for sleep. DSM-5 made some changes. They took obsessive compulsive disorder and PTSD out of the anxiety disorders and gave OCD its own OCD disorders, and it gave PTSD trauma disorders, and the other ones you can read there. These are some more ads because I liked the ads. Xanax used to have its own ad, which look, complements an effective therapeutic alliance. Psychiatrists weren't supposed to be just the pills. We were supposed to be having a therapeutic alliance so we could work on therapy, making them soften them up so we could talk to them, right? But we kind of went astray, I think. Librium, old ad, made people more accessible and communicative. Symptomatic relief of anxiety, hydroxyzine, beta blockers. I have horrible stage fright. If we go back here, agoraphobia or a specific phobia, I'm on that realm. I have horrible stage fright. Do you believe me, honestly? No. I cannot talk in public at all whatsoever, I swear. This is coursing through my system. I'm on a beta blocker. This shit works. How does one pick a correct med? They're like, well, how do you pick the right meds? Well, you need the right diagnosis, right? Because what is a psychiatrist's only tool to have to get to a diagnosis and get treatment? It's a psychiatric interview. I don't have a blood test. I don't have a brain scan. I don't have anything I can do like that. I can't send you for labs to figure out if you got bipolar, maybe depression or anything. So I need to do a good, thorough psychiatric evaluation. How do you get a good psychiatric evaluation? Am I psychic? Can I read what's going on in your mind and what your thoughts are racing or not? No, I gotta build a rapport with you, right? I gotta get you comfortable enough that you wanna talk to me. So rapport building, that's important. Other factors, you gotta understand the odds of certain diagnoses. Bipolar disorder